and policy, the Global Breast Cancer Initiative and Kenya's action plan. So this is October, where we commemorate the Breast Cancer Awareness Month. So also we have this in our mind as we go through these presentations. So we just see the background, breast cancer burden in globally and in Kenya. And also we see the policy framework, breast cancer screening guidelines 2018, breast cancer treatment protocol, a global breast cancer initiative, and breast cancer action plan. So globally, breast cancer has the highest incidence among all cancers, with over 2.2 million cases reported in 2020. With this, the majority of deaths occur in the low middle-income countries. And in Kenya, it is the leading type of cancer, with an estimated 6,799 new cases and 3,107 deaths. And this is occurring yearly, and it was confirmed in 2020 by WHO. Despite being preventable through screening, the rates remain low, less than 1%, with most cases being diagnosed at late stages, resulting in high treatment cost coupled with low overall survival rates. So globally, the burden of the new cases, which were estimated in 2020, that is worldwide, was showing that the total burden was at 19,292,789, where breast cancer was leading, followed by lung, colorectal, prostate, stomach, liver, and then cervical cancer was also there. Global burden on cancer on deaths, again, the estimate, and this is worldwide and both sexes and all ages. Again, now lung is leading in death, followed by colorectal, liver, stomach, breast, esophagus, pancreas, and others. And in Kenya now, cancer actually is the second leading cause of NCD deaths, and has a rising trend at 14%. Those are new cases, and this was found in 2012 and again in 2020. So in incidence, breast cancer is still leading, followed by cervical cancer, then prostate. Then when we look at the deaths, we find that cervical cancer is leading and followed by breast cancer. As we see, these are female cancers that are on the rise than these other cancers. We are not saying that these other cancers are not killing, but the rate that the breast cancer and cervical cancer are killing and they're top cancers, we should actually put an alarm there and see how to control them and not lose the women. Note that the breast cancer is not killing men. Men also are dying, but the percentage is low. So Global Breast Cancer Initiative was done in 2021 by the WHO in collaboration with multi-sectoral stakeholders. Its goal was to avert approximately 2.5 million deaths by 2040. And this was anchored in 3 pillars: health promotion, timely diagnosis, comprehensive treatment, including supportive care. The expected SPA should be collective, global action and provide momentum to halt the rising breast cancer burden. So the first pillar on health promotion for early detection, which is public health education to improve awareness of the signs and symptoms of the importance of early detection and treatment, has a target of 60%, that is an early age where it should be achieved, diagnosis should be at least achieved of invasive breast cancer at stage 1 or stage 2. In pillar 2, which is a timely diagnosis where public and health worker education should get the signs and symptoms of the early breast cancer, so women are referred to diagnostic services when appropriate. And this diagnosis should come with evaluation in imaging, tissue sampling, and pathology. And the time frame should be within 60 days. So within 60 days, the diagnosis should have been got and the problem to be managed. Then we have the third pillar, which is comprehensive breast cancer management. So this is centralized on centralized services and treatment for breast cancer, given that cancer management requires some level of specialized care. At this, the treatment completion should be 80%. So that is at the 80% undergo full course of multimodality treatment and successfully return home. When we see Kenya policy framework, and these are the policy that are guiding us on how to manage the cancer disease or cancer prevention. We have a Kenya Cancer Policy 2019-2030. Then we have the National Cancer Control Strategy 2023-2027. Then we have National Cancer Screening Guidelines 2018, National Cancer Treatment Protocol 2019, National Cancer Specimen Handling Guideline 2020, Breast Cancer Screening and Early Diagnosis Action Plan 2021-2025. Then we have Kenya Palliative Care Policy. So all these documents are available online, and if we can get them, we will get guidance how to manage cancer problems. So in breast cancer screening guideline, it is stating that mammography is the recommended screening method. So complementary methods to aid in early diagnosis are the breast cancer self-examination, clinical breast examination, ultrasound, and magnetic resonance imaging, that is the MRI. Those ones are also used for high-risk groups. Those are, they're actually modalities. They are not screening methods, but they aid in coming up with a diagnosis. So we have age, the age to start screening and the frequency. This one also depends on the risk assessment. And average risk, that is when women are supposed to be screened, is between 40 to 74 years. And then again, we have 50 to 55 years, which are screened yearly. And this we can see tabulated as follows. Age 25 to 34 years, we have CBE every 3 years or 1 to 3 years, depending with the history. If the family history has a history of breast cancer, that then they will be doing CBE yearly. Then mammogram is not recommended at this stage. At the age of 35 to 39, CBE is done, and ultrasound or mammography. Mammography may be indicated only when recommended. That is it is not recommended here, but if there is a reason why a clinician would see that that a particular patient needs mammography, they can be sent for it, and also screening is between 1 to 3 years. From age 40 to 55, it's clinical breast examination and mammography, and this is annually. At age 56 to 74 years, CBE and mammography, and this is done every 2 years. So we have breast cancer treatment protocol, which recommends that all women found to have breast cancer lesion should undergo a triple assessment. So the triple assessment is clinical breast examination, preferably done by an experienced clinician or a breast surgeon, or bilateral breast imaging, bilateral mammograph that is done for women over 35 years, and ultrasound for women less than 35 years, or an MRI as appropriate. Also histopathology and core biopsy. So we have breast cancer action plan. The breast, it was a screening pilot was carried out in Nyeri County in 2019, and it showed underutilization of mammography services. So this formed the basis of development of the breast cancer screening and early diagnosis action plan, which is now guiding us on how to manage breast cancer. So the management of breast cancer in facilities are on levels of care of facilities, where we have a level public primary health care level, secondary level, and tertiary level. So when a screening is done at the primary care level, which is from the dispensary to level 3, where CBE is done, if it is positive, they refer to county referral hospital. If it is negative, they give counseling and send home and give a return date. And at the county referral hospital, you repeat the CBE by a gynecologist or a surgeon. If it is normal, again, they are reassured and advised for CBE after a year. And for high risk, including with family history of breast cancer, they also they are referred for annual screening on mammography. So if the CBE is abnormal, then they are sent for mammography and or ultrasound, depending with the age. If it is abnormal, they are sent for FNA and core biopsy. If normal, they are reassured and sent home. If FNA has come out that is a breast cancer, then they are referred to cancer center. If non-cancerous, their treatment of non-cancerous lesion is provided. And that marks the end of my presentation. And what I'll say that early detection saves lives. And this month, as we are celebrating breast cancer, we are having a theme of rethinking pink, access for all. So let us think pink and advocate for breast cancer screening, so that we can capture the lumps when they are still early, when they can be detected early, treatment is possible.
Thank you very much. That was a wonderful start to the presentation. It's October. Definitely, we are thinking pink, but as the presenter has shown, we need to rethink the pink. We need to make sure we are thinking about it more seriously. The statistics definitely are stuck. The statistics show that we need to really focus on breast cancer. It's high up on the charts, and definitely that means lives are at stake. So as the participants who have joined, let us all unite, wear pink during this month so that we are showing solidarity and focus onto oncology and oncology-related issues, particularly breast cancer. So our next presenter is about primary prevention, screening, and early diagnosis approaches. And our presenter is a fantastic lady who has an experience over 5 years. She's an oncology nurse specialist. She currently is the secretary to the Oncology Nurses chapter in Kenya, and she's also been a trainer with the Ministry of Health on administration of chemotherapy agents. So welcome, Stacey Hollander, for the presentation.
Good afternoon, everyone. Thank you very much for this. We are going to go through breast cancer prevention and an overview of its management and what we are supposed to do as a healthcare providers. So just to start us off, remember there are a few things that you're going to look at. Those are our objectives. We are going to outline the risk factors for breast cancer. We're going to discuss the prevention strategies for breast cancer. We are again going to look at what are the signs and symptoms of breast cancer. Then we are going to describe the screening and early detection interventions for breast cancer. And I'm going to just mention a bit about the cancer management that is available in our country. So we are going to start off with the risk factors. Ideally, the exact cause of breast cancer is not known, but it is closely related to the genetics, that is our gene makeups. The risk factors are classified into 3. They could be modifiable risk factors. They could be non-modifiable. Again, they could be environmental risk factors. What are these risk factors? So the non-modifiable risk factors are factors like age. As the age of a person increases from a young woman to an older woman, the risk increases as their age goes up. The other thing is the personal or family history. When you talk about personal, those patients who have or clients have had a history of having maybe benign lumps previously, or also been treated with with the breast cancer again, or maybe breast cancer of one breast, are at risk of developing breast cancer in the future. Or again, those patients who have a family history where you have a close relative, maybe a mother, a sister who had breast cancer. And this one is closely associated with the gene that carries the breast cancer, that is the BRCA1 and BRCA2. That one is also to describe the genetic factors. Then the reproductive history. As the lady had children, did the children breastfeed? Research has shown us that ladies who have had children and breastfed them have a lower risk for developing of breast cancer. Then the race and the ethnicity, where does the person come from? What are the risks associated with the breast cancer? And then the gender. You realize, as Lillian was presenting, it came out very clearly that it is more common in ladies than in men. So the female gender has a greater risk compared to the male gender. So the modifiable risk factors is what can this person do? The unmodifiable, it also meant these are things that one cannot be able to change. For example, the age must go up. For example, the family history, you're not able to change it. And things like gender, you cannot change it. So what can we do as us to be able to prevent this breast cancer? One, it is to manage the obesity, meaning that we need to have our the BMI at a lower level, not above 30, so that you do not become at risk of developing breast cancer. The other one is smoking. Smoking in cancer, it becomes one of the biggest risk carcinogens, which means that we need to cease smoking for the ones who are smoking. We need to stay away from people who are smoking because of the secondary smoke, because it puts us at a risk of developing the breast cancer. The other one is the lack of exercise, which means the patient or the client ends up being obese. Then not breastfeeding, the alcohol intake, and those clients who are using hormonal replacement therapy. The environmental factors, these are things like, sorry, I left that out. The environmental factors are things like the radiation that maybe comes from the soil that is around us, those things that are surrounding us that we do not have much of an influence on. Those ones are things that are in the environment that leads us to getting the breast cancers or any other cancer. So we are going to look at what are the prevention strategies that we can apply in order to be able to put the breast cancer at bay. And we are going to look at these in the 3 categories. You're going to look at the primary prevention, you're going to look at the secondary prevention, and you're going to look at the tertiary prevention. So in the primary prevention, this one involves health promotion and risk reduction. That is in the general population. And these measures include stopping of smoking, the lifestyle modification. This one you're trying to run away from the modifiable risk factors. So you're stopping smoking, modifying our lifestyle, for example, our diet, and also doing micronutrients supplementation, indicates identification and counseling for the genetic risk factors. For example, if you come from a family that has a history of breast cancer, it means that you're at a higher risk. So these ones calls you and me to be able to start our screening early, to be able to go for genetic counseling, genetic checkups, so that you're able to know if you have the gene, and if it is there, you take the necessary precautions. The other thing is breastfeeding, at least for a year or more, where possible. So again, on the primary prevention, avoiding obesity, a healthy body weight, that is having a BMI that is below 25 or at least below 30. Then being physically active, it calls us to be very active so that we do not end up accumulating a lot of fats in the body that leads us to obesity. Then maintaining a healthy diet, again, helps us to prevent the obesity, avoidance of tobacco, smoking, and alcohol use, and then limit postmenopausal hormone therapy. These are the drugs that most of the ladies take in order to control the menopausal symptoms that come during menopause. So you limit the postmenopausal hormonal therapy. So on the secondary prevention, this one becomes very paramount, especially to us healthcare workers. The main aim of this is to identification and treatment of the preclinical or premalignant cancers. And this is the most important thing that we are supposed to do, that is screening and early detection of the breast cancer in order to either stop or slow the progress, and implementing treatment programs to return people to their original health and function. So our goal for screening and our biggest growth right now comes to screening. We check up those patients, we check up ourselves so that we either stop the disease progress, or if it is there, we identify it early and we are able to start the treatment, the patient or the client on treatment. So screening mammography is a typical example of secondary prevention to detect cancer in its earliest form. Actually, from the screening guidelines, it tells us that mammography is the most ideal screening method for the breast cancer in ladies. So when it comes to tertiary, this includes care provided for patients who are already now diagnosed with breast cancer to reduce the mortality and the morbidity associated from the disease. This level of care will provide will be provided at the specialized cancer centers. So our clients out there, once they have come to us, we have screened, that is the secondary prevention. If those clients do not have cancer, you continue encouraging them to undergo the screening. We are going to look at it as we proceed. But the ones now we get to have the signs of cancer and the cancer is confirmed, we move to the primary prevention, where we are targeting this, the patient getting either dying from the cancer or having serious comorbidities that are arising from the cancers. So once the patient comes to the tertiary prevention, this one becomes a client that goes to the cancer center treatment areas. So for the screening and early diagnosis, breast cancer screening is checking the woman's breast for the signs and symptoms of cancer before the signs of the disease. So ideally, screening, you don't go for screening when already you have the signs of disease. It is that screening of the healthy person who comes maybe every year, every 2 years, so that you are able to check for the signs of the disease before it becomes a cancer. I remember Lilian has closely highlighted this, but just to emphasize on that the methods of detection or screening that are used or supposed to be applied is the monthly self-breast examination. This one is done by the woman herself at home, at least every once a month. Then there's the clinical examination by the health provider. These are nurses, doctors, clinicians who are already trained on screening for the breast cancer. Then ideally, the last but very important is the mammography, which is the best screening, the best test that is used for screening of breast cancer when the lumps are very small and not able to be palpated to the patient by the patient or the doctor. So a lot of this presentation is grounded on the National Cancer Screening Guidelines. If you're able to Google that, you'll be able to see it. You can go through the whole document and understand exactly what we are talking about and what our Kenyan guidelines. But just to again highlight what Lilian had shown, these are the age group and what you're supposed to look at, again taken from the screening strategy. So for age 25 to 34, you do a clinical breast examination, and mammogram is not recommended, and this one can be done 1 to 2 years. For ages 35 to 39, the clients who are on the age of 25 to 34, that is the first category, they are not recommended to have mammogram, but they're supposed to have a breast ultrasound. For age 35 to 39, you combine now the clinical breast examination and the ultrasound or mammography for those clients. The reason it has a star, it is for those clients who are already at risk. For example, a client who has a close relative with breast cancer. This one you can start mammogram as early as age 35. For clients from the age of 40 to 55, you do the clinical breast examination. Again, remember this client is doing the self-breast examination at home every month, the clinical breast examination every year by the clinicians or the nurses, and then there's a mammography that is done annually. Then the rest of the clients, that is 56 to 74, it's almost equal. The only thing that changes is about the interval, that is every 2 years. For those clients who are above 75, these ones now it becomes individualized. You continue checking the clients, but it becomes an individualized work that the clinician or the medical team works with the patient, and again, very closely considering the patient's preferences. So what are we looking for when we are screening? When you look at the signs of breast cancer, you are looking at the changes in the texture or puckering, that is the dimpling that appears. Sometimes the breast cancer signs will look like, will feel a lump. That's why you are doing the clinical breast examination, so that you are able to palpate the lump. The other thing, the nipple could have a discharge, a free-flowing discharge, or the patient could report to you that they are when they look at their inner clothes, they have some sort of discharge. Then is the nipple inverted or changing in direction? Look for swelling around the armpit or around the collarbone. That is the lymph nodes mostly. They could be the lymph nodes and the collarbone, or again at the armpit. Then constant pain in the breast or the armpit. And then there's the change in size or shape, or sometimes there could be a rash, especially when you have the Paget's disease, or crusting of the nipple or the surrounding areas. So just to use an orange to demonstrate how they look like. So there's the big area, there's the dimple, you can see it here, there's the nipple crust, there's the reddening or the warmth on the nipple, there's a discharge which could be bloody or even any other color. Then the patient could have sores. Sometimes there could be a lot of veins that are growing on the breast, or a sunken nipple, a change in shape, and what we used to call the orange pale skin. That is the skin of the breast appearing like the orange skin. And then when you're palpating this patient, you could get what you call the lumps. Through palpation, you're able to feel the lumps on the breast of the patient. So how do we perform a breast examination? Ideally, breast examination should be done by all women of the reproductive age every once a month. The best time of the week that the breast examination should be done is after the period ends, when the breasts are not tender or swollen. So ideally, you give this patient a guideline to come for to do the breast examination between 7 to 10 days post their menses. And you can see from the picture the type of how you're looking at the breast of this patient and what you're teaching your clients to do at home. So this one is a demonstration of how they're going to do it at home. You can tell them to raise their hands to look at if the breasts are rising up equally. Then you can tell them to place their hands akimbo, not so they're able to see if there's any either dimpling or the nipple is inverted. Then you can now tell the patient now to start palpating their breast. They could do this when they are in the shower or when they are lying down, and preferably when they are lying down, so they're able to feel the whole breast tissue evenly. So again, when they come to the hospital, remember this is what the patient is doing at home. So when they come to the hospital, we are going to do what we call the clinical breast examination. And this is now done by a clinician. So there's what position the patient lies in. There's what you start by just observing. If there is any maybe color changes, the dimpling, then now you start doing your clinical examination. Again, most of the healthcare providers working in the breast clinics are able to do a clinical breast examination. But some of the motions that are used is either the up and down or the circular motions when you're doing the clinical breast examination. So the last but not least is the recommended screening guideline, that is the mammography. And you can see a picture of our client having a mammography done. There's an illustration, then there's a procedure of how it's done. And now there's an image of how the results will come like. And you can see the size of the lump that has been seen from the mammogram. This means sometimes you may miss it when you're doing either the self-breast examination or the clinical breast exam. So how do we manage these patients? Once we are able to confirm that there's a problem, what do we do? What is the best guideline on how we are going to handle our clients, or even how the clients are going to be managed? So there's need for further assessment, and it is recommended that we do further assessment will involve triple assessment. That is where we are doing the clinical breast examination. So if a patient comes and tells you there's a lump, now you have to start again by managing. We do the triple assessment. That is where we are doing the clinical breast examination by a clinician who is certified to do this. Then there's imaging, and the most ideal imaging is the mammogram. I've already said that again. And then the last but not least, we take a biopsy. Remember, we do not start treatment of a patient before we have a biopsy confirmed diagnosis. So here we said again, as I had said, we do the clinical breast examination, we do our imaging, which is the mammogram, especially for ladies above the 40 or those with history of breast cancer that is above the age 35, and then we take the biopsy for the confirmation. So once we are able now, for example, this patient, if we now get that we are getting the biopsy results showing us the patient has a cancer of the breast, we now move to the management. And the management now involves treatment. So the treatment options that are available, we have surgery. And during the surgery, we do it in a number of ways. And this one is done by the surgeons. The surgery will include what we call the breast sparing, for example, the lumpectomy, where we are removing the sector of the breast that has the lump. And again, looking at the margins, we go deep enough to be able to get the margins that are positive for cancer. Then the other method of surgery that you can apply is what we call the mastectomy. Mastectomy now is complete removal of the breast. So when you're doing the lumpectomy, we are doing what we call the breast sparing. You're only removing the side of the breast or the lump, the part of the breast that has the tumor, but going again deeper for the edges. The mastectomy now is completely removing the breasts and the breast tissues, including going for the lymph nodes. But especially when it's radical, you go in for the lymph nodes. Then the other management methods are chemotherapy. The chemotherapy, these are intravenous treatments that are given through either the veins for the patient to now start treating and killing the cancer cells. And the target is to remove all the cancer cells from the body. Later or before, sometimes we can do radiotherapy. This is what we do. We use radiation. We do radiation therapy to the chest, so that we try to remove all the cancer cells. Then later again, we do what you call the either biological or hormonal methods of treatment. So just to mention that surgery is available in most of our level 5 hospitals, a number of our level 4 hospitals if you have a surgeon, and also the referral, obviously the national referral hospitals. The chemotherapy agents, again, available in most of our regional cancer centers, again, the national referral centers. So if you're working in a level 1, a level 2, a level 3, a level 4, you refer these patients to the specialized units, maybe the cancer centers, so that they are able to be either get the surgery, and if there's a chemotherapy unit, they are able to get the chemotherapy unit. Now, for the radiation therapy, majority of these units, when you look at the government sectors, are mostly available in a few of the level 5s, that is either Nakuru, Garissa, Mombasa, and also available in the national referral hospitals. The biological and hormonal methods are also available in most of the centers that are doing cancer treatments. So just to mention those ones, the national referral hospitals include the Kenyatta University Hospital, that is the referral hospital in Nairobi. There's also the Kenyatta National Hospital, and we have the Moi Teaching and Referral Hospital. These ones have all of them. They have the radiation, they have the chemotherapy, and they have the other specialized services that are available for cancer. Then chemotherapy services are also available now in the county, the regional level 5 facilities like Mombasa, Nakuru, Garissa, Kisumu, Embu, Meru, Bomet, Kakamega, Machakos, and Nyeri. So what is our take-home message this month? That breast cancer, from Lillian's presentation, is the leading cancer in women in Kenya, that all women should be educated on breast cancer. They should be educated on performing monthly breast examination on themselves. And they should be advised that once a year, they should have somebody that is a clinician doing their clinical breast examination. Then all patients who are above 40 years to 74, refer them for a mammogram at the first instant that you're getting them. Then refer all women with suspicious breast lesions for further assessment at the appropriate health facility. So as we are going around this month and we are trying to rethink pink and helping every lady to be able to access the breast cancer treatment, let's remember to educate our women that we are coming into contact with them in our facilities, in our communities, in our churches. Let's try to pass the message about these three. That is the breast cancer itself, the self-breast examination, the annual clinical breast examination. Then again, do not forget yourself as you're doing this. Remember, you're also a client. Your wife is a client. Your mother, your father, your other female siblings can also be clients. So let's rethink pink and make sure that everybody who can access is able to access the care. Thank you. That brings us to the intention. Thank you.
Thank you very much, Stacey, Halonda. I think the session has been really wonderful. I think we have learned quite a bit about the role we have as individuals, what we can do on day 10 of our menses as women, what we can teach our clients to do, and not forgetting the men too. There is a percentage of men that have been also diagnosed with breast cancer. So this breast screening, rethinking the pink, also involving the men so that they're part of the screening program and we can catch the cancers early. So thank you very much for the wonderful presentation. So we're going next to our presentation, which is baseline cancer. We are looking at the baseline assessment in the year 2022. It's important for us to know where are we as a country. And Dr. J.P. Bor Malenya will be the one taking us through the presentation. She's a program manager, prevention and early detection at the National Cancer Control Program in the Ministry of Health. She's a public health specialist with interest in non-communicable diseases. She has over 15 years of professional experience in the Kenyan public sector, including over 10 years in the clinical care and hospital management. She's currently the lead for the cancer prevention and early detection pillar in the NCCP, and her roles involved the development and implementing of policies and programs towards the implementation of the National Cancer Control Strategy. One of the guidelines that has been repeatedly mentioned, the National Cancer Screening Guidelines in 2018, she coordinated its development, and she's really keen to see the advancement and harmonization of the cancer screening program. And she also coordinates the National Teaching Working Group on Cancer Prevention and Early Detection. And she has a master's in global health and communicable diseases from the University of Edinburgh. So we're very pleased to have you, Dr. JP Bor. Kindly take us through the baseline assessment. Where are we as a country?
Thank you so much, Dr. Wanda. Thank you, my co-presenters, Lillian and Stacy. So to our audience also, thank you for being here, and thank you for the attention that you're paying. And just to, as Dr. Wanda has said, where are we as a country is what we want to understand. And I want to request that you bear with me in case of any background noise. I am actually going to be using my phone for this. And I hope that we'll be able to communicate. Lillian will project for me my slides, and I will take us through. So just for context, we want to understand now that our breast cancer guidelines, you have heard about them. They recommend mammography as the gold standards, for screening, the primary screening method, where you have had the definition of screening. And our action plan tries to customize our guidelines to our local situation. We want to understand then what can we do as a country that is available. What can we do with what is available? So the first step in implementing our action plan is to understand where are we, and that's why we conducted this baseline assessment in 2022, and I'll be telling you more about it. It's a facility preparedness that we are assessing as we mobilize clients. Then, as we mobilize the clients, then how are our facilities prepared to receive them? So Lillian, please confirm whether you are able to share my slides.
We aren't able to see the slides yet.
Lillian is supposed to project for me. Lillian, are you in a position to, or Dr. Wanda, if you're able to, you could also do the same. I know
I'm not able to trace them. Maybe if Dr. Wanda is in a position, she can go ahead.
Lillian, I had sent them to you on email. Sorry, I got caught up in a hospital somewhere. I had a patient, so that's why I'm not able to present, to use my laptop. But I believe that with the help that I'll get, we'll still be able to have a successful session. So Dr. Wanda or Lillian, please confirm if you're able to share my slides, or if not, or even Stacy, any of you can do it for me, please. And I beg for the understanding of the audience today. I'm very sorry that we found ourselves in such a situation today. Okay, Lillian has started sharing. Lillian, I would need you to download so that we can get the full screen. So that you can expand the screen. Meanwhile, maybe Dr. Wanda, if we can address some of the questions as we set that up, would that work?
Yes, I think that's a good idea. We can be addressing some of the questions. So in the question and answer, the first question was, can the screening be carried out in the age between 20 to 30. And Stacey, you took us through some of the screening and you gave us the guidelines. So kindly, Stacey, perhaps you can answer to that.
Ideally, every lady of reproductive age should be undergoing the screening. But a recommendation from our strategy that is in our country gives us from age 25. So from age 25, they should go. But again, talk to the lady to at least to be doing the monthly breast examination and that clinical breast examination. The ultrasounds start from our guidelines. It starts from the age of 25.
Maybe I can also clarify your needs. Yeah,
Yes,
that yeah, it can be done, especially for those who are at a high risk with the family history of breast cancer, or those that have BRCA mutations. So it is possible that it can be done, but we should be guided with our breast cancer action plan and screening guideline. Thank you.
thank you very much. So that just emphasizes the need of individualized care based on the history. Some patients, you find their family history, the cancers presented very early, which would necessitate us to do screening early, but the guidelines are also clear on how we should go about that. And then how does limitation of breastfeeding cause breast cancer? And how does this affect young women living with HIV that stop breastfeeding at 6 months or earlier? Lillian, I don't know if you would like to take that up.
I don't know if Stacey, you can answer it, but I'm thinking it is hormonal. When there's, I don't know, Stacey, can you answer that?
I wanted to kick it back to Dr. Wanda.
It was coming back to me. I didn't see that coming. But anyway, definitely when you have a long period of exposure to estrogen, meaning unopposed estrogen, which would mean nulliparity, not having children, not breastfeeding, then the hormone levels are high. Remember, when you breastfeed, it sort of works like reducing the hormonal levels. That's why you're not able to conceive, especially the first 3 months if you do exclusive breastfeeding. So that just has to do with the hormonal level. So when you have long periods of estrogen exposure, then that's a risk factor. So how does this affect young women with HIV and those that stop breastfeeding at 6 months or earlier? Generally, breastfeeding is encouraged. However, we would not force. Remember, we are living at a time where circumstances are different. Some women have to go back to work, so they might be forced to express or maybe not even breastfeed in the case of those living with HIV. So remember, we do case-to-case analysis. And when we know the history, then our focus on the risk stratification then is a bit higher. But we wouldn't say just as an independent factor that not breastfeeding alone predisposes you to breast cancer. Remember, the cancer is multifactorial and we have multiple etiologies that would put a person at higher risk. So yes, it's a risk factor, but not as an independent factor. So I think I can see the presentation is now very well visible on the screen. So maybe we can give Dr. Bor the opportunity to take us through where we are as a country, and then we can go back to the question and answer.
Yes, thank you. Thank you so much for your indulgence. And here we are. I want to take us through the breast cancer baseline assessment report for 2022. Lillian. Next slide. So in brief, I'll take us through the background, I'll take us through the methodology, the findings, the discussion and recommendations, and then we'll come to a conclusion, just highlighting that this is based on the breast cancer screening and early diagnosis action plan. So the methodology for this baseline assessment that we did, it was a survey that we carried out to, as I said, to inform and support the implementation of the breast cancer action plan. It was conducted at county referral hospitals, sub-county hospitals, and select high-volume health centers and dispensaries in 25 counties. We did this between August and September of last year. In the map that you can see there, those are the counties that we focused on. And the reason for selection of these counties were involved in the first phase of our cervical cancer screening program rollout. And so during our activities around cervical cancer, we always speak about integration. We always push and promote for integration of breast cancer intervention. So we felt like there was a level of awareness in these counties, and we thought they would give us a good sample. So we collected data using an online survey, using a validated data collection tool. We trained county focal persons for cervical cancer, or NCD coordinators, to conduct the survey. Next. And the goals of the assessment are here. The goals of the assessment were to review the existing capacity for breast health care services, identify the relative strengths and weaknesses of the health system in providing breast cancer screening, early diagnosis, and linkage to further management, and then also to assess the community engagement and outreaches for breast cancer screening and early diagnosis. We actually have the report, as you have seen it there, the findings. So starting with the how many facilities participated. Out of the 25 counties we invited, 22 participated, a total of 439 facilities, different levels of care, as I mentioned. And our finding, but most, one of the main findings, one of the key findings was that 99% of the facilities actually did offer clinical breast examination services. All these counties that participated had at least one ultrasound and one mammogram in level 4 or level 5 of their facilities. But there was a problem with equipment maintenance, whereby there were significant delays in repair when there was a breakdown, often more than 2 weeks. The facilities that we assessed, the ownership, this is how the ownership was and the level of care. For most of them were actually GOK facilities. That is almost, a very big proportion, together with faith-based organizations, accounted for 99.5. Privates were very few. And in this, you can see that level 2, the light pink was level 2. Majority were level 3 and 4, and then level 5. Also, according to the number of these facilities that are available, generally speaking. And for faith-based, most of them were level 4 facilities. Lillian? So on the clinical breast examination, I told you that almost 99% of the facilities had these services. They were performed. These were the different levels of care that performed. Majority were level 3 and 4 that were offering, and that was the profile. So this is a good finding for us, because we advocated for, you saw in the guideline that Stacy presented, that from age 25, we're supposed to do clinical breast exams annually. So it is good to see that the facilities are actually doing and have that capacity to do it. Next, Lillian. So on imaging, I told you that there's one mammogram and at least one mammogram and at least one ultrasound in each facility. And who is performing this? So out of the 57 facilities that provided ultrasound and mammography, 33 were level 4, 24 were level 5. Generally speaking, in terms of staffing, there was at least one general radiographer in 84% of facilities and one sonographer in 77%. Of note was that there were no breast imaging radiologists. And speaking of general radiologists, they were there. The deep pink there represents the general radiologists, but mostly available were the sonographers, and then the general radiologists and general radiographers, but there were no breast imaging specialists in the 25 counties. And that is a significant finding, because when it comes to mammography, it needs that expert. So the next one was, how do they follow up if a client has an abnormal ultrasound or mammogram? And this was the finding. Either they are referred to a surgeon, referred to an external facility, sent for biopsy, sent for FNA, or referred to a breast surgeon. So we found that majority of the facilities refer to a general surgeon, mostly within the facility, and then almost 30% were referring to an external facility. Now, very few clients would get sent for a biopsy directly. That is around 21%, which is about a fifth of the clients. You heard about the triple assessment, and so you can see the reality on the ground. Next, Lillian. Breast biopsy methods that are used in the facility. It can either be excision, like excision biopsies in theater or in casualty, FNA, palpation guided needle biopsy, or TrueCut, what is called TrueCut, or ultrasound biopsy guided. Can be ultrasound or palpation guided, or needle biopsy, or referral to external facilities, to another facility for biopsy. We found that 16 out of the 22 counties had biopsy services. Many counties actually, a good number, these ones here, they lacked biopsy services. Bomet, Homa Bay, Isiolo, Kajiado, Marsabit, and Wajir. I don't know if people from those counties are here, but that was the situation. And then 47% of the facilities processed the samples at the lab facility. The rest, which was now a bigger proportion, outsourced the biopsy processing service. So histopathology is a key issue or a key gap in our counties. Next. Facilities offering lab services. Here we are looking at FNA cytology, we are looking at histopathology, we are looking at immunohistochemistry, which is important for determining treatment for breast cancer. We found that histopathology services were available on site at 10 level 5 facilities in 7 out of the 22 counties. So about a third of the counties only were the ones who had histopathology services. This were Kakamega, Kiambu, Kisii, Machakos, Meru, and Nakuru. And then we also noted that none of the facilities actually provided immunohistochemistry. This service is not available widely for our clients. Next. When it comes to community engagement, advocacy, communication, social mobilization, demand generation, we found that 77% of facilities use community health promoters. Now that's what we are calling them in the community, so that they can create awareness on breast health, even teaching clients how to do the breast self-exams. 95% of the clients conduct health talks in the health facilities. That's a good one, so that's an opportunity. And there was a challenge with, there were no IEC materials in most of the counties. So that was a challenge. So when it comes to mobile clinic services, 54% of the facilities, that is in 19 counties, provide mobile clinic services. So 19 counties provide mobile clinic services in about half of their facilities. Among the 237 facilities with mobile clinic services, majority offer CBE during the mobile clinics. None provide mammography. You know, there are digital mammograms that are portable. There were none. There were none available in the 25 counties. And then one facility reported that they did point of care ultrasound, only one. Yeah. So what do we conclude from this? Looking at, we use the WHO 6 pillars of health to delineate the strengths and the weaknesses of our health system. So in terms of service delivery, I have mentioned CBEs being available, that's a major strength. The weaknesses are in linkages and follow-up after abnormal tests. The quality can also be an issue, and histopathology is also an issue in service delivery. It's a gap. When it comes to HPTs, health products and technologies, this includes equipment. We have ultrasound and mammography available, but commodities are a challenge, and maintenance is also a challenge, equipment maintenance. Human resource for health, we found that actually majority of the CBEs were done by nurses and clinical officers. Kudos to the team, and sonographers were also widely, at least they were available. But the weaknesses were on pathologists, radiologists. I mentioned there are no breast imaging radiologists and other technical staff. Then on health information, we found that most facilities use the MOH 412 screening register. This is the cancer screening register in Kenya. And the other strength was having the community health promoters and health talks in terms of passing on information. The gaps were in patient tracking and lack of IC materials. Unfortunately, our survey did not directly assess elements on leadership and governance and healthcare financing, but maybe in future, we will look into those. So finally, I think we are going to the final slide. Lillian, and this slide is on recommendations. We have about 5 key recommendations based on the findings. The first one is on the need to integrate clinical breast exam services in all facilities, where we need to target service delivery points where women present as part of the core services. We also need to increase availability of services to enable linkage to further assessment and care at level 4 and above facilities. So we need level 4s to have imaging, to have diagnostic biopsies and triple assessment. Then also the other thing we need to consider is improving access through telereporting. This is like for mammography. In other countries, what they have done, they have a centralized facility where the mammograms are sent for reporting, or even the reports that have already been done are sent to the central site for quality monitoring, because that's very important in a screening program. The other thing that we need to do is to establish rapid diagnostic clinics. This is a one-stop clinic, one-stop shop, where a client will get the triple assessment. They will get a CBE by an expert. They will get a core biopsy and they will get the CBE, they will get the imaging, either a mammogram or ultrasound, depending on their age, and the other patient factors. And then they'll also get the core biopsy, and this will be guided by the ultrasound or the mammogram as necessary. We have one such facility in the country. We have one at KU, the Teaching and Referral Hospital. What do they call it? TRRH, Teaching, Referral and Research Hospital. So we have one there which we launched last year in 2022. Yes, last year around this time. Then the last thing that we recommend in summary is to address the challenges in the workforce, both availability and capacity or training for the health workers to provide the breast health services. Thank you. And I think finally, I want to conclude that there is need to prioritize breast cancer early detection in the county NCD and also in the cancer agendas in the county through enhanced target setting, communication, coordination, and quality improvement structures. From a national level, we have this, we provide this, and this needs to be cascaded downwards. Secondly, there needs to be deliberate investments in clinical research to improve breast health service delivery within the Kenyan context. This will inform policy and also inform the practice for it to be appropriate and cost-effective. I want to end by calling you to action. Lillian? Yes, the call to action. Really, the conclusion that I think the 3 of us presenters have given is that the early detection for breast cancer remains the cornerstone for controlling the disease. What is the situation in your county or in your facility or even in your country? Because I know we have international participants here. What is the situation? And what can be done? What are the barriers? What are the facilitators? Please think about this and think about it and see what can we do at your level, as Dr. Wanda has been calling us also to think about what we can do at our level. And with that, I want to thank you for your attention, and back to you, Dr. Wanda.
Thank you very, very much. That has been a wonderful presentation. We really enjoyed to know where we are as a country. We're happy to know there are steps that have been made. There are very many facilities that are able to do the diagnosis and actually offer treatment. Yes, the more needs to be done, but at least we are somewhere as a country, and there's always room for improvement. In every house, they say that's the largest room, so definitely there's a lot we can do. I can see a lot of applauses, thumbs up, pom-poms flying around saying thank you for the presenters. You've done a fantastic job tackling the policy aspect of breast cancer awareness and what we can do, and the claps are coming more and more. Thank you very much. You've been a wonderful audience. I think now we'd want to go to the questions, the question and answer, and then we see how we can answer them. I'm seeing most of the questions are targeting the getting the points. So thank you very much, the KNH team. I hope guys will get their CPD points so that we can move on. Then why is the ultrasound early and mammography later? What is the rationale? I think someone wanted to see why are we doing an ultrasound for young women and why mammography later? I don't know, Halonda, whether you can take us through that.
Yes, I can. So the reason we are doing the mammogram at a later stage and the ultrasound at an earlier stage is because of the density of the breast. You realize at a young age, the breasts are a bit dense, meaning that it's not able to, it's not easy to be able to like get the X-ray for them as compared to the older age when you're able to now, like the fat tissues are reduced and you're able to see through them.
Thank you very much. So the density is actually key. And then wonderful presentation. Is there support for patients with breast cancer as far as access for all is concerned? I do see many patients with breast masses. When you advise them to biopsy, that's the end because they're so vulnerable, they can't afford. And most of them opt to go home and continue with herbal remedies. So I don't know if there's any support that is there. Maybe Lillian, you can tell us, is there any support that is there for patients to have biopsies taken?
Yes, we have been pushing the NHIF to cover part of some of these treatment or diagnostic issues, but part of it, I think, is now covered. Before, they were not covered completely, but I think right now, something is being done by the NHIF to cover. So what we do, we urge and advocate for people to enroll on NHIF, more so that they can get the support, because you'll find that those who cannot support completely, also they don't have NHIF cover. So if they have NHIF cover, I think at least part of it, even if it is not all, can be catered for. Thank you.
Thank you very much. We also in the past, we've seen there's a role for the social workers in hospitals, the different hospitals we work in. So sometimes engaging the social worker, some of these fees can be waived so that we get a diagnosis. And then how can we assist a patient who is supposed to have mammogram and they do not have money? I think the money aspect is really coming out. I don't know, Dr. Bo, at a policy level, what are we doing? Because mammograms are, I don't know, how do we help the patient?
Yes, that's a good and a very valid question. And as Lillian said, we have been advocating and lobbying for NHIF to support not just even diagnostic mammograms, but even screening packages within their packages. It is unfortunate that that somebody registers for NHIF, they pay, but sometimes they don't even use the service, or they wait until they are sick only. And yet their screening is not covered. So that is a gap, honestly. But one thing is we're also advocating for counties to charge very free rates, very, very subsidized rates. I know many counties charge around 1,500. Others charge maybe 2,000, 2,500, which are still beyond the reach of some patients. So anyway, for now, I may not have a very straightforward answer, but what we are lobbying for is for NHIF to cover screening and for people to register on NHIF. Meanwhile, even as we talk about mammogram, many have not even done the basic clinical breast exam. So we are encouraging our clients to even start with the basic annual clinical breast exam. Yeah, so I think let me leave it there. Thank
All
you.
right, thank you very much. So there's what the government is doing, there's what the counties can do, and even us as individual lobbying the social workers to see whether very needy patients can get assistance at that level. And then there's a question on kindly advice, is breast pain normal, like the one you get before menses, but it might persist through your cycle? Is that something that you'd consider normal? Stacey, I don't know if you'd like to take that one up.
Yes, I can answer that. If it's cyclic, it is normal. But again, there's no harm in getting a checkup once you feel that things are not as normal as in your body is changing. There's no harm in that. But if it's cyclic, it could be normal. But if it is not, or it's a new development, the advice is let the client have the clinician have a test on them. Depending on the age, take up the screening. Remember, screening should happen continuously from the age of 25. So any new symptom, any new development of a sign or a symptom should be checked up during the clinical breast exam.
Right, thank you very much. And then there's a question on what are some of the ways of monitoring the prognosis during the treatment period. So there are many ways. There's a clinical assessment where we look at how is the mass shrinking in size. Then we have the radiological where we could do scans like CT scans of the chest, the abdomen and pelvis, and compare to the scans we did before treatment. And using that, it can really help us know, is the tumor reducing in size? Is the patient progressing? PET scan can be used at the end of treatment to assess what was the response. Now that would be a biologic or a functional imaging that we could use. So there are many ways we assess treatment progression, and I think it's really individualized based on the symptomatology and the clinical picture that the patient has. So there's a question, in my view, screening mammography should be ideally avoided in pregnancy and lactating moms. Breast tissue is highly sensitive to radiation during the two phases. I don't know if you'd like to comment on that, Dr. Board. Do you think we should image because of sensitivity?
No, I don't think so. I don't think it's safe to image during to do mammography. It's a form of X-ray. I think it uses the same principle, so it should not be used during pregnancy. And then I also want to just point out that we have a webinar series the whole month covering the whole continuum of breast cancer care, from now prevention and policy where we are today. Next week, there'll be a webinar that will, I think, focus on diagnosis. Then another one will focus on treatment. So some of the questions I'm seeing in the chat are focusing on areas that will be covered by even experts in those areas. So I want to recommend to the...
I think we lost you there, Dr. Bor, but I get. So maybe a question we could take up, is there a reporting tool for routine breast cancer screening?
Lillian?
Yes, there is. There is a tool for screening. Actually, it is for both breast, cervical cancer, and colorectal cancer. That is 742. It's a screen. It's a screening tool. It captures all those three cancers. So if you have that particular screening tool, it captures the three.
Lillian, I think you mean MOH 412 cancer screening register.
Yes, 412 register, exactly.
Yes, MOH 412, and the summary is the one that Lillian mentioned, MOH 745. It should be available in your facilities, and if it's not, please reach out to us and we can send you soft copies so that you can print. Thank you.
Right, thank you. So I think the last question we'll take for today is someone has said their community health assistants graduated and it's their first day with us today and they've learned a lot. They want to find out, they need to do a lot of education in the community. Is there any support where they can get materials? What support do you offer for someone who would be willing to carry out awareness campaign in their community?
So,
Maybe, okay. You can go, Doc. I was actually asking you to speak.
All right, thank you. Thank you so much and congratulations on graduating and on joining this webinar. You're going to make a difference in your community from even what you have learned today as a community health assistant. So I want to mention that we have a curriculum for training community health promoters, and the curriculum is actually available online on MOH website. If you just go looking for CHV or Community Health Volunteer Cancer Training Manual, you'll find, and you can refer to that and read it. Although we would actually prefer to, when we have opportunity, we train the CHARs, and the other community health resource persons, then they train the CHVs. The other useful link that we have a link where you can access IC materials, including a fact sheet that you can use to educate the community. Do you think, Dr. Wanda, we can be able to post that link somewhere in the chat or in the Q&A, or where can we post it so that people can access it?
Sorry, I was
Maybe.
muted. I think we can post it on the chat so that everybody, the attendees, can see that link.
All right, I'm going to find the link and post it as we end, so that you can access. Click on it as soon as possible so that you don't lose it, so that you can access the materials. Thank you.
So that's really fantastic. As I said, that was the last question. I'm seeing people who are still asking more questions, but as we mentioned, we're going to have a lot going throughout. So let's follow the cancer series. And then there is a question about, is it normal to have a discharge? I think this is important for us to discuss. Maybe Stacey, you can take this up. It says, is it normal to have a discharge that is not actually liquid? It's creamy, but does not flow. It does not stain the bra, and it's been there for some years now.
I take back the question and I ask, has she had any form of screening done? Ideally, the patient should just, now it becomes individualized, that you're able now to check the patient, look at the radiological examinations, what are they reporting? So from there, we take it up depending. We can't say it's normal or not normal. Maybe it could be normal or it could be abnormal. So it's always good to go for the screening. And again, you follow it up with a doctor that is able to now follow it up, what is happening and what kind of management is available.
I strongly agree. It might be difficult to answer, like what Stacey has said. There are so many questions that one would have for that patient. So I agree. It's very important to go through the screening so that that can be looked at by a healthcare professional and imaging being done, especially if the person has not been lactating, then it's important for it to be addressed and looked at into that. So I'm posting the link shortly so that we can see the IEC materials. I think that's important for us to know. Where do we get information? If you want to, I've seen some people also asking whether they can get some what is it called? They can get some materials to talk to others. Can they download materials? Are we going to share the presentation? So I think this is quite important for us to go through. So I'm posting the link. Make sure you click on it, because after the session, you might not be able to see it. So I've posted it. I don't know, maybe somebody can give us a thumbs up when they're able to see it. Has anybody been able to see it? The link. Just give me a minute. Everybody's saying thumbs up. I don't know what that means. Have you seen it? I've ended up clicking it and now I've gone to the page myself. Are you able to see it? Anybody? Somebody? For some reason, I am not getting a response. So I don't know what that means. Are people seeing it, not seeing it?
We are able to see it. I don't know if
you're able.
Yeah.
Okay, fantastic. That's great. So if we can click on the link, then we can be able to see. I've seen people have raised their hands, so I'm hoping that means they're able to see the presentation. So thank you very much. You have been an amazing audience. I hope the take-home message is early detection saves lives. There's what the country is doing. There's what the counties need to do. There is what we need to do as individuals. People are saying no, they're not able to see it. Not here. I think they're not able to see the link. I don't know if that's just me. Everybody's saying they can't see it. KNH host, are you able to post on the chat as a group, kindly? So that the team is able to see it. Thank you.
Dr. Wanda, I have also given you links. The
Yes,
link
I've seen
where
your
you
link.
can access the MOH website, where you can access the screening guidelines, the breast cancer action plan. Also, if you follow, around that page where the link is, you'll get the CHV training material. And I also see some hands up, though I think time is not on our side.
Yes. So kindly, KNH host, are you able to copy and paste so that the participants can see? I am unable to copy and paste from the chat. Kindly assist so that we can send to the participants, and then we can call it a day. Kindly, KNH host.
Come again, I didn't quite get you.
I said kindly post the link that has been shared on our chat so that all the participants can access it. There are 2 links that have been shared. I'm unable to share them.
Once the link is shared, you won't be able to copy it. Zoom doesn't allow for copying. So kindly, I'd ask the person who posted to kindly post it again. But this time I'm going to change who's going to receive it. So everyone is going to get.
So Dr. Bo, maybe you need to share it again, because apparently it's the laws of Zoom that are not making us able.
All right, Nelson, I'm ready to share. Where do I share it?
Just send it to the chat. Now you'll be sending it to everyone.
Oh, that's very nice. I didn't know that. So
yeah, that's nice.
I hope everyone has seen the link. That link goes to the IC materials. I want to also share the link for the breast cancer action plan and screening guidelines. It's the same link. What you'll have to do is, look for the what you want on that site, where I'm going to link just now. Wonderful. I can see that you're saying you have linked the second link there, written guidelines. If you follow that one, you'll be able to get the guidelines and the action plan and even the CHV training materials. Thank you.
So thank you very much, Dr. Bora. Thank you, Stacy, for the presentation. Thank you, Lillian, for your presentation. You've been a wonderful audience. Thank you for participating, for asking the questions. We look forward to seeing more and more. I would like, just as we leave, I would like to project what we expect to come through this week, so that as an expectation, you can look out for our presentations. So just give me 1 minute for me to do that. We can be able to share the topics that are coming up so that you're aware, you can look out for the presentations, and then that will be a great way for us to continue learning together. So if I'm allowed to share my screen, I'll do so in a minute. Share screen. So I don't know if you're able to see my screen. Somebody can confirm whether they're able to see my screen.
Yes, we can see your screen.
All right. So what we've had today is the 6th of October. It's on Word, so you'll be able to see it. 6th of October is the Breast Cancer Series 1. We had policy and prevention. The next, we expect to have Series 2, where there'll be the triple assessment. We've had discussions about it today, but now it will be in more details. We'll have, how do you do the clinical breast exam? How do we image? There were questions on imaging. Kindly keep those questions about the mammogram. Do we do it in pregnancy or not? about biopsy. What does a biopsy entail? Why is it important? That will be on the 12th of October. Then on the 19th of October, we'll have now the clinical management and M&E stroke research. We'll be looking at what are the presentation, what are the symptoms, how do we manage breast cancer? What about if it's a benign breast mass, a non-cancerous breast mass? What do we do with it? That will be on the 19th of October. Maybe you can mark that in your calendar. And then on the 26th of October, we'll have a breast cancer series, how to have supportive care and survivorship. There was a question on depression. There was a question on how to manage the patient support and also advocacy. That's very important. And that will be on the 26th of October. So it's a month packed with activities relating to breast cancer. We are looking forward to being with you. We're looking forward to having you in the audience. So thank you very much. And now I would like to put the meeting to a close. Have a lovely evening.
Thank you very much, Dr. Wanda. You've been a wonderful moderator. Thank you, Stacy, and thank you, Lillian, for the great presentations.
Thank you.